yes, there's a place for them, but I would question that in all cases, and I would take them out as soon as you can. Drugs. As I said, if you haven't found a toxic drug, you haven't taken a drug history properly. Let's just talk about a couple of important drugs. All of our patients nowadays, everybody in the community is either on an ACE inhibitor or an angiotensin II receptor antagonist. Ask your mother or your grandmother. They'll all be on some of these agents. They're excellent for hypertension, they're excellent for heart failure, they're actually good for a lot of kidney diseases, they're universally used in diabetics and so on and so on. But they alter the way in which blood flows through the glomeruli of the kidney. And that's fine in health. But the point is this: if any of you become septic, you will try and divert blood into the kidney to actually increase glomerular filtration rate and get rid of some of the waste products that you're generating during your septic crisis. These drugs stop that from happening. And what that means is that I think if you've got somebody coming in under your care and you look at them and you say, bit of renal dysfunction now, and they've got all those risk factors, I think that's going to get worse, then I would stop these as soon as they come in. There are a few people in whom left ventricular function absolutely demands these, but in the vast majority of these patients, stopping them for a week or so is not going to do them any harm and may just rescue kidney function for the time that they're with you. Non-steroidal anti-inflammatory drugs. Lots of your grandmothers are only mobile in the community because of these drugs, but they too are impacting the way in which blood flows around the kidney. And again, I think they should be stopped on a mission for a large number of people. And you're looking at me like I've got 5. Bloody hell.
You had to catch an eye on that.
Damn. Any new drug that has recently been started in terms of 4 or 6 weeks' time can cause acute renal failure. Let's ignore trimethoprim. 2 quick things. Radiographic contrast media. If you come into hospital nowadays, the first thing a surgeon will do is order a contrast CT of your entire body before they even see you. Radiographic contrast media can cause and exacerbate acute renal failure, and there are ways of avoiding it, but I would always question whether or not it needs to be done. Gentamicin. You're all taught, don't give gentamicin to patients with acute renal failure. Actually, it's a brilliant antibiotic. This is in actual fact is the opposite from all of the others. It is still a brilliant antibiotic with a huge role to play. I think people should receive it when necessary, but with advice. Right, if I've got 5 minutes, I will cut to some things which I think I heard people wanted to hear about. Renal replacement therapy. When is renal replacement therapy necessary? And this is not the dialysis requiring chronics that I look after. In terms of acute renal failure, the first thing I think is this: I find that it's overused. I tend to come on and do ward rounds to find that so-and-so was dialyzed overnight, and I have to say, well, why? We could have waited. Everything is better in the cold light of day. And the only mandatory reasons to dialyze somebody are hyperkalemia that's resistant to medical management and fluid overload that's resistant to medical management, and almost everything else can wait. Terminal uremia nowadays is not that common and also rather difficult to define. But this is my other thing, is again, I occasionally come on the ward and find that so-and-so was dialyzed overnight, and you then go through everything and you say, but in actual fact their acute renal failure was part of a sort of pre-terminal disease process anyway, when you consider their age, comorbidities, complications, and so on and so on. And I think before we put people on dialysis, we should ask 2 things at the bottom. What is their likelihood of recovering renal function? Because if it's nil, then the other thing is, are we going to start and then commit them to a chronic dialysis program? And if the answer to both of those is we shouldn't, then we shouldn't. Difficult in some instances. Fluids. I think I find this quite easy. One of the problems we have in hospital is every single fluid cabinet is full of 257 different types of fluid, and you go, oh my God, which one are we going to use? And at the end of the day, stick with 3, don't use the others, and I'm not even sure I really care which of these you use. The point is just use a fluid. And what worries me slightly is there is a tendency to go, oh, I didn't want to give too much fluid, or any fluid, because I didn't know which one to use. Right. 0.9% saline, 5% dextrose, both standard things. There are so many colloids. Just use one. Know how to spell it. Know what the volume is.